And for our final presentation this morning, we're going to move to a different part of the world, and Kemi Tesfazghi will be standing in as the presenter for this work on plantation-based case management in Cambodia, data-driven evolution, and Kemi's with Population Services International.
Thank you. I'd like to thank the organizers for allowing PSI to come and talk about the work we do on plantations in Cambodia. So a few facts about malaria in Cambodia. You might have heard over the last few days that we aim to eliminate malaria by 2025. There's about 8.5 million people at risk, and there's widespread resistance to ACTs. In 2017, we had over 60,000 cases, and increasing this year. And malaria is forest-related, with those at most at risk, men aged 15 to 49. So at the inception of the PSI Worksite program, our overriding question was, how can we effectively provide free, quality malaria case management to mobile populations? Mobile and migrant populations, because they moved in and out of areas of high endemicity, and they were attracted to forest-related work based on plantations and around plantations. So we thought worksites, set up case management on worksites. So here's a very simplified buckets of activities that we use to set up worksites. First is identifying, mapping, and engaging the worksites, then providing, recruiting, training volunteers to provide case management on worksites, and then establishing a system of reporting. So I'll talk you through each of those one by one. So the first is finding those worksites. Now this first step shouldn't be underestimated, because some of these plantations like to keep their business private because of the kind of work they do. So there's a whole process of engaging them, which I'll come back to in a minute. So in 2013, 2014, we went about mapping all work sites in 18 provinces in the country. So we mapped about 1,400. And then we carried out full interviews with over 500 of these work sites. And those 500 were selected based on size, presumed risk, and also some practical measures such as the presence of at least 80 workers on the work sites. We then engaged the work sites and started the process of engagement. So the process of engagement, conducting intensive introductory meetings. This is to gain access, to build trust, a very slow process for getting them to understand that we don't care about your business, we want to make sure that your workers are protected. And then we'd hold orientation workshops in conjunction with the local authorities where possible. And then this was effectively the public launch of the program. So this is where we are today. We're present in 9 provinces. We support over 160 work sites and support over 250 volunteers. So once we knew where, and we've engaged the work site, the next process is selecting the volunteers. We do this in conjunction with the work site owners and managers. We train them according to national treatment guidelines, and then we'll provide access to quality tests, RDTs and ACTs. We provide incentives, supportive supervision, coupled with quality assessments. We then went about setting up a system of making sure that they were reporting. The first is through paper-based reporting to filling out the forms. Then we introduced electronic reporting in about 2016 using the malaria case surveillance application. And that all goes into the PSI-supported DHIS2 system, where data can be visualized and acted upon. So apologies for the business slide, but this is just, the point of this slide is to tell you that the work we do helps support the government to get data from these work sites and integrate that where they can into the national picture, surveillance picture, so they get a full picture of what's happening on the work sites in both public and private sectors. So we've set up work sites, we've gotten volunteers, they're now reporting, and sometimes that goes into the national system. I want to spend the last section of my presentation talking through some of the questions and some of the ways in which we've used data to improve what we've done. The first is, how has data improved what we do and where we operate? So looking at this graph, the caseload from worksites 2013 to 2016, you see that in the beginning we were getting positivity rates about 20 or 30%, which in our context was pretty high. But then, so our conclusion at that point is great. Expand the worksites, drive up the testing, you'll continue to see cases, but you can see that those positivity rates went down. And I'll come back to those going down positivity rates later, but in terms of driving up the testing, some of the things that we did was we introduced performance-based incentives to the volunteers. So where before they were guaranteed to get the incentives, we made it so that they had to test at least 5 people to get the incentives. We also introduced mass screening coupled with deworming, so we partnered with the local health authorities, and so when they conducted deworming campaigns on the plantations, we invited people to be screened. We also integrated things like condom distribution and distribution of ORS to give a fuller package of services. We then went about doing qualitative studies on what the barriers to testing on work sites were. So some of those barriers were lack of awareness of the risk of malaria. So in response to that, we ramped up on-site BCC, further engaging the worksite managers and team leaders. Then also, we found that the volunteers didn't really trust the workers didn't really trust the volunteers' skills, because I don't know about malaria, why should I trust that you know anything about malaria? So we started increasing the visibility of the volunteers to make the workers understand that they were partnered with a reputable organization. And then people who worked with community health workers would know, the availability of the volunteer was really an issue, because after all, these were full-time workers. So we decided to transition, where possible, the profile of the volunteers from full-time workers to shopkeepers, so that people could integrate their health seeking with practical things like shopping. And then we also realized that the volunteers were providing a limited amount of services. So like I said, we introduced like the condoms and the ORS, but also having the shopkeepers do some of that work was also helping with that. So now looking at the picture of, post-2016, we were seeing good testing. So that spike you see in 2017 is really as a result of the huge effort we put into the mass screening during deworming. But we found out that the positivity rates were still not improving. And when we looked at the positivity rates during the mass screening, it was less than 0.5%. So in 2018, we haven't done mass screening of that sort, and we're shifting more to focus screening, so really looking at those who are at risk. Because during the deworming, when you look at who is being tested, it's about 50% women, and like I said at the beginning, we're more focused on men, really. In 2018, we started looking at at the end of 2017, we started looking at reactive case detection. We started looking at reactive case detection. We piloted this in 5 work sites. So what we did was that we had our field officers incorporate this into their supportive supervision. So when they went out, they'd take cases that were reported through the app in the last 2 weeks. They'd follow up on those cases, do a short interview, see if they'd been to the forest. If they had been to the forest, we'd ask if they had co-travelers. If they had co-travelers, we'd screen those co-travelers where we could locate them. If they hadn't been to the forest, then we'd screen their family members. So in 2017, the last quarter of 2017, when we did this on 5 work sites, we saw positivity rates about 5% compared to the 0.5% of deworming. So this was better. This was the strategy that was working. And so we scaled that up into 24 work sites in 2018. We followed over 400 index cases. We conducted over 800 tests, but the positivity rates have gone down to about 2%. So we're going to be reviewing that strategy and see where it continues to make sense to continue doing that in 2019. We also then decided to look a little bit about the composition of our network. We found that in 2017, only 14% of our worksite reported on average at least 1 case per month. And then 80% of all our cases came from only 25% of our network. And 36% of our worksites did not report any cases at all. And up to that point, we had treated all of them equal, same amount of love and attention. So we started to rethink our strategy. We ended up with coming up with an approach of stratifying. So we stratified into 3 priority groups based on caseload, proximity to health centers, and proximity to PSI-supported private providers. This is a delicate process because the priority 3 work sites, we were moving away from the on-site case management to provision of BCC materials and referrals to health facilities. But given the amount of time and effort we had put into engaging them, we have to be careful about that process. The priority 2 work sites are the ones that have the model that I described earlier. So it's the basic package, the normal package. And then the priority 1 work sites have sort of the enhanced or the plus package. So they have the priority 2 worksite activities, the on-site case management. In addition, we do training of team leaders. We do screening upon entry, like you were asking about. And we also do focus screening on the work sites and around in communities, informal communities around the work sites. So I've talked about how data has helped us to improve what we're doing and where we're doing what we're doing. I want to spend the last few minutes looking at how data has helped to improve the quality of the case management we've provided on site. So on this slide, the bar graph is the quality assessment scores of private providers supported by PSI, so like pharmacists and clinics, as well as volunteers we support on the work sites. The green bars are the Class A providers. So when we assess them, we classify them into A, B, C. So A being the highest level of achievement, and the blue is Class B, and the orange is Class C. And you notice that consistently from January 2017 through to December, there's increases in those providers who are classed as Class A. But when you look at the data disaggregated, the donuts on the right, you find that when you look at the private providers, 83% of them are Class A, so we're doing pretty well there, but the volunteers are not performing as well. There are several reasons for this, including the fact that the private providers are often at least have some level of health background, whereas the volunteers are plantation workers. So we decided to do something about this this year. So this is a simple internal document that was developed by my colleagues in Cambodia in response to this issue. It's a provider monitoring sheet, and what the field officers do is that before they go out and carry out their supportive supervision, they print this off, and each row, my apologies, I've just given away the end. Each row is a provider, so it tells you about what they've reported, but most importantly, it tells you their last quality of care assessment and the areas in which they struggled. So for this particular provider, we see that relative to RDT procedures, they're not performing as good on introduction, on counseling, so different aspects of what they're assessed on. So this sheet helps the field officer, when they're performing supportive supervision, to engage with the provider on a level that makes sense to them, on a level where they're struggling, and help them to improve that. We found that by implementing this in 2018, the Class A providers went from about 47% of our network to 72% of our network. So a vast improvement of the volunteers who are working. And this is only for volunteers on work sites. I'd like to leave you with 3 takeaways. One is we have to tailor effective strategies to where we're working. In Cambodia, we say same, but different. So we know what works, we do it, but we have to be mindful of what the plantation workers are doing, where they're going, how they're acting on an individual level, and then tailor our strategies to meet them at the point of their need. The same thing goes for the individual behavior, to make sure that the providers are exhibiting those behaviors that we want them to do. Meeting them at the point of their need, engaging with them in the areas in which they struggle, and helping them build their capacity. And then finally, we can't do this without having a culture and promoting a culture of data use, looking at collecting the data, that's quality, looking at it, and constantly asking ourselves how we can do better. Thank you.
Go ahead.
Hi, Kemi. Thank you so much for your presentation. I had a question about the performance-based incentives. And I was curious, what's the testing criteria that's used for the volunteers on the plantations? And how do you ensure that meeting that criteria of 5 tests per month, that they're testing really those at risk rather than those that are just around them and kind of convenient sampling with the testing they're doing?
That's a really good question. So the testing criteria was based on national treatment guidelines. So presence of fever or 2 of other named conditions. To be honest with you, we haven't looked at whether or not they were just testing the same people over and over again, but in the case application form, it's line listed, so we have for positive cases. So that would make sense for the positive cases, but there's no way to know that they're not testing the same people over and over again.
Well, if there are no more questions, thank you very much. Oops, we have one.
Good morning, everybody. My question is this: the incentives you give to the community health workers, do you follow them through to know the impact of the incentives to have a more sustainable plan? Because I know in some countries where you have incentives for the health facilities, you follow to know the impact they're using that money. So do you have any plans in doing that?
That's an excellent question. As a matter of fact, we've just finished a piece of both a study that is both quantitative and qualitative, looking at the motivations of the provider. And I am embarrassed to admit that, surprisingly, it's not the incentives that motivates them. It's like my other panelist was saying, it's the motivation to contribute to eliminating malaria and contribute to their community that really helps. And then the level of incentives we provide is quite modest compared to the full-time work, which is why I alluded to the fact that we have problems with the availability of the workers.
Okay.
Thank you.
Thank you.
Great. Thanks again, and I'd like to thank all of the presenters for some great talks, and also wanted to thank my colleague for a wonderful organization of the symposium. Thank you, Darlene.